today some background about yourself. So I'm sure many people who have dialed in know Nik either personally or by reputation or both. But for those who haven't met Nik, Nik is currently Group Director of Research for Epworth Healthcare, and he's also an adjunct professor at Monash University in Victoria. So Nik's background is cancer biology, and he developed statewide biobank infrastructure in West Australia, which I think was his first foray into biobanking in this country. And he also led the development of national guidelines for human biospecimen use by the NHMRC. So this year, Nik took up an advisory role with the Office of E-Research at Queensland University of Technology in Brisbane. And he's also a chief investigator of the clinical data analytics platform that's funded through the Digital Health CRC. And that's to facilitate electronic medical record data access to support research across Queensland and New South Wales. He was also a founding director and board member of the Australian Clinical Trials Alliance ACTA, and he's chair of the Primary Care Collaborative Cancer Trials Group, which is PC4 Advisory Group, which is and he's a member of the PC4 Scientific Committee. He's a board member of COSA and chair of the Cancer Biology Group. So he's a busy man, and we're very grateful for him to give us his time today, where he's going to talk about eConsent and why eConsent is a major advance for informed consent in the biomedical research.
Well, thank you. Thanks, Jen. And that's a very generous introduction. I'm very interested in this topic, which really has emerged over the last 12 months for me, at least. It's a lot older than that, as it turns out. People have had interest for well over a decade in use of electronic media to facilitate consent. And so I just wanted to spend a little bit of time today going through probably some of the sort of ethics background to this work and where it sort of fits in terms of the current processes in most organizations. I am doing a little piece of work for CTIQ via Chrysalis Advisory. We did a report last year which looked at what were sort of barriers or enablers to use of eConsent for clinical trials, specifically for clinical trials, not necessarily in biobanking. And that work was quite interesting, and I'll give a little bit of a summary of that. And then talk about the work that we're doing now, which is really revealing how many people are actually already using eConsent. And I can see Matilda House is online. She'll be giving a talk next week, which will go into much greater depth about use cases. So I'll limit myself in this presentation about those. So just some, hopefully this can advance. Here we go. Hopefully everyone can see the screen. Is that being shared yet or not?
Not yet, Nik.
Not yet. All right, let me just share that and put this up. Here we go. Can you see that now?
Yes.
Yeah.
Excellent. So we often ask, what is the purpose of consent? And most people who work in medical research are very familiar with why the necessity for obtaining consent. But I just want to run through it a little bit, because I think that there are a couple of issues which need to be considered. The primary ethical reason that we discuss consent is about respect for people, and as an expression of the autonomy of an individual to make choices about what they do with their lives and about the way that they interact with others. And that's particularly important. So it's actually an expression of a meaningful relationship between the researchers and the participants, rather than necessarily just an exercise in bureaucracy. It's also empowering, and we know that when research has been done around reasons why people might give their consent. There was an interesting case in the UK some years ago where they were looking at opt-out consent for biobanking, and a number of the consumer groups, when reviewed, objected to it. And they objected in part because they felt that it robbed them of a sense of their own empowerment and also their altruism. their ability to be able to give as part of the process. So it was just if there was an assumption that they had been included in a research project, it somehow took away from their own power. And that can be particularly important in diseases such as cancer, where people feel quite disempowered by the experience because they're very much at the under the care of the team that's looking after them, and that can be a very disempowering feeling. Although it's important, and I'm not dismissing it, the compliance with guidelines and legal requirements, I think it's become a little bit too weighted toward that. And I'm going to explore that theme a little bit in this presentation, because I'm particularly object to the term of consent as a verb. Have you consented the patient? As though it was something that was done to them, rather than it was something, as I've explained here, that is given. So consent should be given. And the reason we do it, obviously we need to do it and we should be doing it, but purely to say, oh, well, we've done it because now we've complied with the legislation. And that to some extent has driven the legalese that has crept into patient information sheets, and some of them are bafflingly long. And we know that consumer groups, and we work with them very closely in oncology, they really don't like these long consent forms. But legally, it is suggested that it's a requirement of disclosure to make sure that all of the nuances are there. And work that we've been doing in ACTA has been looking at proportionality. We're about to publish a review. It's just going through the final stages of its review, which is looking at proportionate disclosure for things such as comparative effectiveness research studies, where we're comparing two or more standards of care that are already in practice and looking at what is a reasonable disclosure. In some instances, it's been suggested we should almost be disclosing the risk profile of aspirin to the nth degree, rather than just giving the standard warnings that would be given with any prescription of an over-the-counter medicine. And so you can see that there would be a massive disparity between its use in everyday practice and when it's used in a clinical trial, and it really should be done in a proportionate way. So just to reiterate what the national statement says, that respect suggests that it's voluntary and it's informed. Now, what do we mean by informed? And informed is a subjective rather than objective assumption. We suggest a person has been informed because we've given them a bunch of information and they've said yes to, they've asked questions, we've answered those questions, we say, are you sure you're happy to participate? But research studies have also demonstrated that when people do this, they actually are far less informed than they really think they are. And I can provide references if people are interested afterwards to that. But, you know, worryingly, even in things such as phase 1 studies, actually a very large number of the doctors didn't realize that these are not likely to derive a benefit to the patients. And even the researchers themselves sometimes misunderstand the purpose of the study, which is very scary. So what do we really mean by informed? And the national statement actually makes a clarity about this, saying this information must be presented in ways suitable to each participant. So it has a tailoring of it, and yet there is a uniformity of the way it's delivered, in that we have a standardized text that is approved by the ethics committee. The ethics committee themselves don't give approval for who is going to be meeting with the participants and taking them through the documentation, answering any of their questions, and the process itself that happens when it happens. But if we turn to paragraph 5217, it talks about information should be presented to participants in ways to help them make good choices. And it goes through a series of bullet points there about the way in which that can be provided. One of the problems I have with the current process of the almost sole reliance on reading information sheets when you're on an ethics committee, and I should disclose I'm not bashing ethics committees, sat on one for about 15 years in total, and even chaired one at one point. There is too much reliance, I think, on the written patient information sheet, when we know that actually there's a context and that people will go away and they'll look up things on the web and they'll look at other information, they'll discuss it with a whole range of people, and we can't control that. We don't know what it is that they're reading. The other issue here, B in particular, is about the need for accurate and reliable translations. We know that it is an unjust exclusion in Australia, and we ran seminars on this recently through Cancer Council Victoria and a clinical oncology meeting last year, about the fact that people from culturally and linguistically diverse populations are excluded from a lot of clinical research, from clinical trials in particular, because the documentation is not provided in English. And in fact, being able to speak English is a requirement or an exclusion criteria for recruitment. We generally don't take into account culture and its effects on the language is used, and there's a whole various other range of topics there which can impact on how a person gets their information. So the work that we did with Chrysalis Advisory and CTIQ last year, and I'll provide a reference to this, is now published. MGA we've had a perspective accepted for publication, which will come out, I hope, shortly. We presented this at the NHMRC symposium last year. So the eConsent itself is actually a whole suite of technology, and it's not just an electronic record of consent. It's the whole suite of how we deliver information and how we record that. And so it actually can involve animations, videos, images, podcasts, links to websites, all sorts of things. And it can go even to its probable endpoint at the moment is a completely dynamic process by which people can interact. If there's an enduring relationship, which there is in most consent processes, unless you're doing a one-off questionnaire or just a simple sample collection. But the real richness of doing any research project is to have longitudinal follow-up and to have further interactions with people, answer additional questionnaires or go into any of these kinds of areas. And that dynamic consent is very important. I was first put onto that by Jane Kay, who works between University of Oxford and Melbourne University, and she really was ahead of the curve in sort of suggesting these mechanisms for interactions, and even before the technology was really there to be able to do it. So what did we find from our survey? There's a problem with using paper-based information, and I had a surprising number of people who said nothing to see here. About a third of people said paper was fine, but a majority thought they were too long, and a lot of people, more than half, thought they were too complex. The other thing is that 2/3 of our respondents, and they were made up of a mixture of researchers, ethics committee members, and some consumers, believe that eConsent would improve comprehension, but they didn't necessarily think that would mean that people would be any more willing to participate. The large majority, well, 60% said that there was an issue with presentation, as I mentioned before, for cold populations, and that this could be a potential solution. It was interesting, though, that there was a perception amongst many that ethics committees wouldn't approve of the use of eConsent or would have difficulties with that. And I'll come on to that, but I haven't found that to be the case in at least the biased sample that I've taken of people who have actually reviewed eConsent to date. And when we ran this in a workshop last year for CTIQ, a very large number of people suggested that there would need to be some explicit guidance around the use of eConsent for ethics committees, so that there was some uniformity of approach across the country. And with the exception of one ethics committee, which is the Sydney Local Health District, I haven't actually found any explicit direction on ethics committee web pages about the use of eConsent, but I have visited 60 of those web pages of public and private health services, but I could have overlooked those, and the last time I looked was in December. Certain demographics were identified as likely to struggle with eConsent, and it was interesting. Some people thought that people as young as 60 and hurtling towards that milestone. I don't find that 60 should be considered old, but it was an interesting perspective that some people felt that more elderly people wouldn't be able to use technology, and certainly we haven't found that to be the case, and that's a surprisingly paternalistic attitude. The IT infrastructure was identified as likely to be a problem, and that's because people were using saying, well, we need iPads, or there's instances where there might be failure of the infrastructure around the wireless networks in hospitals and settings, or the inability for people to access that. Using my hotspot phone at the moment to do this, and the NBN saying they can't come around to my house for another week. There are always workarounds with some of these technologies, and if we design these correctly, we could have them work offline as well. There was a number of people had significant issues about data governance, security, and privacy, but a third disagreed with this. And again, it comes down to what people understand about privacy and about data security. The encryption mechanisms are more secure than Facebook and Google and a lot of the other, or as secure, certainly. And then the other question is, why would anyone want to hack these kinds of information, particularly where there is complete separation of a personal identity from the data that's held about them? And having worked on the International Cancer Genome Consortium, and actually still chair the patient participation group there, that has not been an issue by being able to segregate the data adequately and make sure that people can't be re-identified. As I mentioned, there was a lack of standardized guidelines, and I'll come on to the cost, because a lot of people believe that cost would be a barrier to uptake, and that may in fact be the case. There is a cost, but we need to offset that against potential benefits. So what do we know about eConsent? Well, we know that the FDA are very supportive, and in fact during COVID they've now issued additional guidance and provided free tools for supporting the use of eConsent, electronic informed consent, and they provided this guidance for IRBs, investigators and sponsors, back in 2016. And what I really like about part of this is that the term informed consent is taken to task. It's mistakenly viewed as synonymous with obtaining a handwritten signature, when actually what they're really talking about is a process. And whilst we don't need to necessarily cover off the CFRs here, although there are some people who believe that we have to, where Australia is still its own sovereign jurisdiction and doesn't need to necessarily abide by these. But the elements, if you actually read these, are quite consistent with the Australian privacy principles and the national statement in any case. So compliance is very likely to occur just by simply complying with our privacy acts and with the national statement. Transcelerate have also produced eConsent implementation guidance, and I provide a link to this at the end. And they've got some nice graphics about, what they call digital patient engagement, which is a nicer way of talking about the eConsent, but it really goes around whether or not people can have tiered levels of consent, so you can provide information that doesn't make someone have to read a 20-page document just to get the headlines, and can make a decision whether they want to go to the next step. So you can say, well, we're doing a research project. Do you want to even think about a research project? Yes, no. And then it's a gradual revelation of the information as a person guides themselves through their own process. And using biometrics, electronic signatures can be very reliable, and there's two-factor authentications and all sorts of processes that can be done to be able to do that, and collect a great deal of metadata, which is not possible with standard written information systems and paper-based forms. There's a summary within the document, and I won't labor it here because I can invite you to read their own document, but really there is significant patient-focused benefits, as well as benefits for health authorities, sites and sponsors, which really are about improving communication and being more efficient about the way that communication is given, recorded, and the oversight for it. Now, from a legal perspective, we've had some interesting conversations, because people say to us, well, we're not sure that eConsent is legal. Well, it is and has been since '99. So the summary of this act, as far as I understand it, I'm not a lawyer, so I'm happy to take any criticisms from people who are more learned than me. But it certainly indicates, from what I understand from the legal advice that I've received, has been that you can convey electronically anything that can be committed in paper, and particularly in the medical framework, electronic disclosures and the use of electronic media for providing information and recording consent is all legal according to any of the state and federal acts. IQVIA have been very engaged in this space, and I'm going to just use one of their use cases briefly, which is a document that they provided about secure consent. It's not an advert, and I receive no funding from them, nothing to be implied by this. But I think the important process is that secure consent does not replace the dialogue between medically competent site staff and the patient. And I really want to reiterate that, and I'm just pulling from the site here, is that there has been sometimes an assumption that the e-consent process is it's an either or, when it's not at all. It is essentially a tool that can be used to deliver information in another format. Equally, I'm just going to go through some very quick examples here, just mindful of time, but we have within Sydney, I first came across Rebecca Saunderson. She's a dermatologist based at Royal North Shore Hospital, who actually diagnosed my son with cold-induced urticaria, when he went into Bondi Beach. So she did that over the telephone without even and having a photo of the lesions on his body. So she was doing electronic medicine way ahead of the curve. She has set up a company that produces videos, and in full disclosure, I'm actually using one of those at Epworth Healthcare in a clinical trial we're doing for my mobility app with Zimmer Biomet to produce information for patients. But she published this paper in recently and in Journal Dermatology, and it's really demonstrated in a clinical trial that patients were more informed and more satisfied with the information given. And I can provide a link to the paper. It's an open source paper there. Equally in Melbourne, this was a study led by Alice Trong, who's just recently completed her fellowship in Susan Walker's group. And they published this as well just recently in the Australian New Zealand Obstetrics and Gynecology Journal. And it demonstrated that women undergoing caesarean sections had improved information as rather than written information. So they didn't power it in particularly to demonstrate that it was better or the cost savings, and they certainly want to look at that into the future. But it was a good adjunct to informed consent process for caesarean section and was rated very highly, and they do also want to now look at using that in different translations. So that's another good example. And I won't labour this because this is Matilda's talk next week, so I'll just flag that she'll be presenting a bit more advertising for you to attend her presentation. There's a list of these that we will produce on the CTIQ website. I spoke with Claire Scott last week from Cartwheel, and she's going to be very happy to demonstrate the e-consent process that they've got for Cartwheel. Angelman syndrome, Matt Bellegarde and his team have been working very closely on, and I work in Matt's team for Angelman and also for MindOz, M&D Oz. New South Wales Health Pathology have a project which has been approved through the Hunter New England, which again will feature no doubt into the future. WeHi have a COVID Shield project, and as I said, Epworth's doing a project of its own, and I'll provide some links and I'll provide access to this presentation at the end. So I'm just going to make some final comments about cold and regional rural. These groups really are underrepresented in research. And we know that if, and may not be applicable to these communities if we don't include them. So there is really an ethical issue of justice if we miss out on participation in research. Equally, we know that e-consent facilitates access to the information, so that for regional rural, it also means that they can people can obtain the information at home rather than having to come to the clinic, and they can almost do some of their pre-screening. And I'm aware that for telehealth, groups like the Garden Kinghorn have already utilised this, and it also does facilitate then and avoids wasting time when people come into clinic because you can do some of the pre-screening. and obviously it can be translated in multiple languages. So because we're moving particularly to a telehealth model as well, there is no reason why we won't be able to do consent entirely through a telehealth model, and I'd be very interested in some of the discussion to understand what people's objections to that might be. I was interested in the Queensland directive under SOP 90, which suggested that people had to hold up to the screen the fact that they had their ID and how that would be registered. But there are some very clever ways of making sure that we have registration of people and we know who they are when they give their consent. So the Australian experience to date, there isn't any explicit guidance to use it or not to use it. And as I said, Sydney Local Health District is the only one that actually has advice about REDCap. But there's lots of projects that have used electronic methods over the last 5 years, and we'll be featuring some of those on the website just to help people identify others. The intention there is just to provide links to the groups who've used it and to the ethics committees that have approved them, so that they can read about them and that they can go and learn more about what might be suitable for them. The ethics committees that I've spoken with to date, that when I say I haven't spoken to the ethics committee, but to the executive officers, of course, have suggested that there were no ethical issues that they identified for the use of electronic media itself. Some of them just said that the way that the clinical trials were designed to show benefit were what they focused their on from an ethics perspective. So it was methodological analysis. Patients to date have been either at least or more satisfied with use, and the data security is no different to paper eCRFs that are already in use. So the considerations are that if it's really not that much, no difference in terms of practicals, and it doesn't replace personal interactions, and we've got to stress, and this is the FDA say this, and it's equally in legislation here, that if you don't actually need to, I mean, when we take a consent from a person, when we ask them for their consent, when they come into the clinic, we have already established their identity. And if it's part of their medical registration, we don't need to do anything additional. So the question is, why do we need to do that for electronic formats versus paper forms? And actually, the recording of consent using electronic forms, and at Epworth, we are fully electronic with all of our CRA signs and everything else. Oh, I think I might have dropped out and back in. Just confirm that. Anyone want to yell out and say, all good?
Yeah, you're fine, Dave.
Yeah, is that the consent is more reliable than a wedding signature, and we can still make the paper options available to people who choose this, and the most of the websites make that available. So institutions should establish standardized procedures, and I think there is a great opportunity within Australia to work together to harmonise some of the ways that we do this, so that there isn't a non-level playing field across Australia. And that's really the purpose of why CTIQ is doing the work it's doing, is to encourage harmonisation. There is a cost. This is my final slide. We're always going to have a cost for doing things. We were able to fund the animation for our trial at Epworth through a philanthropic grant, internal grants. But we are doing an evaluation of the cost-benefit ratio. And because of COVID, we've had to look actually to changing the way that we do our operations. We don't have a pre-admission clinic open at the moment, and it's quite likely for the foreseeable future that we won't be running one. So for an NHMRC funded trial, which is a comparative effectiveness trial run by Trish Peel and her colleagues, which is a infection control trial called ASAP in joint replacement, we're working with Matt's team at the moment to develop an electronic consent to be able to enable that. And in fact, it's likely to save money. Well, we currently employ nurses to sit in the pre-admissions clinics and to meet with patients, and we're going to look at systems to be able to move to electronic formats and telehealth and do a cost-benefit analysis of that. The question is, will it lead to better recruitment? A lot of people didn't think it would, but I think there's a lot of companies who try to use electronic methods to scrape information out of data systems, electronic medical records, to identify patients suitable for recruitment. But the real critical question about that is, how do we engage with those people? And so simply identifying them isn't enough. We need to have a better method. And I would like to personally see greater accessibility to regional, rural and cold communities be really one of the major drivers to address the current injustice that we have of, and we should also include Aboriginal and Torres Strait Islanders in this too, because we don't reach out to all members of our community at the moment. And I really do think that the electronic framework is one that can address that. And there's just some references, and I thank you, and hopefully there's lots of time for questions.
Oh, Nik, thank you very much. That was really great, wonderful, and I think that the point at which you ended, talking about the importance of social justice and inclusion of all members of the community in research is just so important. Also to actually derive results that are likely to be robust and all-encompassing. I'm sure that we'll have many people wanting to ask questions, so I've just put in the chat that if you'd like to ask a question, maybe just flick that into the chat and we can call on you. But if anyone has got a question, please, jump off mute and feel free to ask it. While people are thinking, I just wanted to say that if you'd like for any of your resources to be flagged on the Statewide Biobank website, we'd be happy to do that. And I think you mentioned a manuscript that's dealing with that issue of proportionality.
Mm-hmm.
Do you have anything that you could it's an interesting concept, isn't it? So is that something you could discuss a little bit more now, like how that's kind of considered?
Yeah, absolutely. It's coming out shortly. It's still under review through ACTA. So I'll just share my screen again. Here we go. Can you all see that?
Yes.
Yeah.
Yeah. So one of the things we were looking at was for low risk ethics review. So this was one of the things about comparative effectiveness research. And as you can see, John Zalsberg will forgive me for all of his editing. But we produced a document here, which is about whether or not we can get that proportionality done into clinical trials. So I think we will be able to do that. And we've got a similar document now being produced for the threshold of information that should be given for participation in those kinds of trials to be judged as low risk, because we're suggesting that there isn't any greater risk for those studies than a person would have if they were to come to the clinic on any given day. And so the level of disclosure should be proportionate to that. And I think that's true of biobanks as well, where we're using leftover material where there's no additional risk to the person. There should be a proportionality of disclosure around how that information is given to people. So, those are the kinds of things that we're working on at the moment, and particularly emphasizing working closely with consumer groups to weigh those up and to provide advice onto the kinds of levels of disclosure that would be given if we were to do that work.
Yeah, that sounds
shortly.
Very important, I think. Just in view of sort of, minimising unnecessary burdens on researchers and ethics committees to have studies appropriately classified if things are truly low risk. If they can be considered as such, I think that can reduce workload for a lot of people as much as, anything else. Now, look, I can see Craig Geddes on the line, and Craig, do you want to ask a question?
Yeah, Nik, thank you so much. A great talk as always. My question is about credentialing the identity of a remote participant. So especially if you're face-to-face, I'm not showing you my face, but you know what it looks like, and it's not very nice to look at. If you're face-to-face with a person in a telehealth setting, then it's obvious that you can see someone completing a consent in real time. That's okay. You're credentialing the identity. But if, for example, you've got the something like we're aspiring to with the COVID-19 biobank, if the person is remote and consenting without ever speaking to the person running the study, how do we know that it's that person who's completing the consent? What are the methods that you mentioned? You alluded to some of them.
Yeah. So two-factor consent, you can do things where a person has to register a mobile phone number as well as their email, and then they are sent the text message, and then they use a code to enter into authenticate who they are. Now, those are the kinds of pathways we use in most systems for authenticating identity. But I think we can also look at it from a slightly different perspective and say, why would someone want to fill in a form when it isn't them? And why would someone particularly give consent to a medical procedure, to participation in a clinical trial, and then take on the responsibilities that would come with that? And of course, anyone who's coming into a clinic for participation in a clinical research project, we would likely identify them at that time. So if they're having any kind of medical procedure, they will have to provide identification when they come to clinic. So I don't actually think there's any danger of a person giving their consent in that way. And for the ASAP study, one of the things we're looking at is a registration and consent remotely, and then an assent either by initial thumbprint or whatever else it might be when they come to the clinic on the day of admission to confirm that they have given their consent. So there are different mechanisms that are tailored to the particular study. So again, I don't think there's one solution to it. But things like registries, questionnaires, people can fill those out. And look, I guess, someone could be mischievous and fill in a questionnaire more than once. We know that we can prevent people from doing some of those things using IP blocking. I mean, I tried to fill in a survey once. I'd forgotten I'd done it, and I think it was for one of the airlines. And it said, no, you've already done this survey. You can't log in a second time. So, there are electronic means by which we can do that, which are in everyday usage.
Well, thanks, Nick. I can see Toby's got a question.
Yes, thanks very much, Nick. I'll definitely agree with Craig. That was a very, very interesting talk. As part of developing the eConsent solution for New South Wales Health, one of the things that has become a point of interest in terms of the discussion with ethics committees is the method of managing the data that is obtained during the eConsent process. So where we're simply talking about forms and the like, we may have an association in a REDCap database or something similar between a participant's ID and the fact that they've given consent. But where we're talking about the transmission of electronic information, that can extend to a digital signature and other data which might be considered a lot more confidential. In dealing with ethics committees, have they seen, has there been any feedback about the method of capture and storage for that confidential set of data? And has there, if there hasn't been any kind of feedback from ethics committees, is there some information that you've obtained through developing your own consent modules that was relevant either in a legislative sphere or just in a due diligence sphere?
Yeah. Okay. So interesting question, because it's actually about where does the responsibility for this lie. I'm going to probably take a contentious view on this. I don't think it's the ethics committee's role to understand necessarily the technology side of it. That's actually a governance issue. And that's why I talked about harmonization and about having industry-based standards and a reliance more on that end of it, with some kind of level of accreditation or certification about process. Because really what we should be saying, the ethics committee says, are you keeping the information confidential? What are the risks to the participant if the information was to be released to the general community? Now, we often say things to the ethics committee which are throwaway lines. Are we going to keep it in a locked cabinet? As I wrote for a joke once in one which wasn't picked up, surrounded by a shark-filled moat. We just write this nonsense. It doesn't actually address the ethical concern. The ethical concern is what happens if the information is released to the community and harm could arise to the person. What are the processes by which you would mitigate that risk? And the only way to do that is to do a proper privacy impact assessment and to use accredited industry standards for that. So then the question is, well, where are those industry standards and who says what they're supposed to be? And New South Wales Health has provided those and says sort of in a circuitous way, well, you've got to go to the ethics committee to get approval, but these are the things that we expect you to do. So my emphasis would be more on process and certification accreditation of that process to say, this is the industry standard for encryption. This is the industry standard from point-to-point transmission of data. This is either acceptable or not acceptable. And then when you submit to the ethics committee, you're simply saying, we're using an industry standard format for protecting a patient's confidentiality. Here are the specific risk factors that relate to that person in this context. And that is quite context dependent, because if it's information about mental health, that might be considered differently to information about ingrown toenails. So it has to be sensitive to the setting and the context in which it's being taken. So I think it has to be a slightly more nuanced, but my emphasis would be, can we come up with a national harmonized framework that people agree upon standards for data collection, transmission, retention? And if we can do that, then it becomes less of an issue for an ethics committee each and every time to assess it, rather than focusing on the ethical issue, which is what happens to a person if there's inadvertent disclosure.
Thanks, Nick.
Thanks, Nick. Kevin, I think, Kevin, is that you, Kevin Spring?
Kevin.
You've got a question. I'm wondering if he's still there or on mute.
Yeah, okay. I'm muting. So, hi, Nick. How are you going? Nice to see you. Just got a question about dynamic consent and what the current data was on the uptake by patients, and whether you think dynamic consent is useful for biobanks.
So the answer is you'll have to go to Matilda's talk, because she's going to tell you all about their experience, and I haven't used as much of it yet. Matt Bellegarde's group have a dynamic consent built into one of their registries, and it is certainly something that we're looking for CDAP for the clinical data analytics platform that's been funded. I think it's a format, as Craig was saying, that could be adopted for the New South Wales Health Biobank for the COVID cases, particularly where there's going to be community or longitudinal follow-up of people about the long-term health effects, even for people who aren't hospitalized. So I think dynamic consent really comes into its own for cohorts and for population-based studies, and I think that's where it really is important. So from a biobanking perspective, I think it's definitely the way that we should be thinking. There is obviously a cost for working in this way, but I think the likely benefit of the richness of information that's going to go with the specimens is going to probably counter or validate, give value to the investment. So a more targeted approach to doing the studies, noting that there's potential for bias in the way that we sample. So we'd have to be careful to control for that bias. So I think dynamic consent, and maybe we can, Matilda's talk next week, but also we can come back and talk about the platforms as they develop. I'm sure Matt would be delighted to share some of his information as well.
Nick, look, I'm wondering, there's still, hang on now, Jane's got a question. Jane Carpenter. Jane, do you want to go ahead?
Yep, fine. Hi, Nick. How you going?
Yeah, good, Jane.
Long time no see.
It is.
I've just got a question about, I think this is definitely the way forward, how this is going to fit with the national statement, and should this be included in that, and how an updated version of the national statement and guidelines within that. Yep. So
the national statement is under rolling review now. So they update sections and then release those sections. And there is a piece being done at the moment on clinical trials. it's something that we've sort of raised with Ingrid Winship about as the current chair of AHEC, and with Jeremy Kenner, who's one of the officers working there. We'd like to see something in there. However, what's interesting is that reading the national statement, and if we take the line that eConsent is actually not fundamentally different, it's not anything that isn't possible under the current national statement. You don't actually have to change any law, you don't have to change any guideline to be able to do it. It's just a matter of almost convention, adopting it by convention and utility. So there's been nothing to prevent ethics committees granting approval. There's been nothing to prevent it at any legislative level. So I think really this is one that maybe we should just leave to building a community of practice. And as I say, part of the work we're doing through CTIQ is to build that community of practice and to share all of our experiences with one another, so that people learn from it. As I said, there isn't going to be one perfect way to do it. Some people will use video, some people use animation, some people use links, some people use dynamics, some will use a once-off, some may even just use PDF versions that are scanned and sent through. So I'm not sure that the NHMRC through AHEC are likely to go into great detail about this. But then I don't know that they need to. If we as a community can come up with our own version of practice that is acceptable.
Yep, sorry. Yep, great, thanks. I mean, I agree with you, but people do tend to use it as a single source of truth.
Yeah, and it is, but I love the fact that it's already written there. It's almost like, who would have thought that it was prescient, 5117, that it allows you to do it.
Great, thank you.
Nik, I guess I was thinking during this about the, in terms of consenting children for research, there's the issue of reconsent at 18. So if somebody's consented, prior to the age of 18, that someone else consents for them. Do you think that eConsent could kind of help manage that transition? Because I know that that's, it's one of those things that it sounds easy, but actually it's not easy at all. And whether having that kind of e-link might facilitate transfer of the consenting person from one identity to another.
Yeah, that's a very excellent suggestion. I hadn't even considered that one. Potentially, yes. And I suppose it's that question of opting in at that level of providing the links, providing the means for a person to be sent information as they become of age. But I guess it's the same thing as if we look at the current process, which is to write to them, and we're saying, well, we're replacing that by some other means of contact. The only thing would be obviously to try and maintain a registry of their contact details to make sure, and that's one of the difficulties, is keeping them up to date and knowing that a proportion of them don't want to be have any communication after a certain point. So I think it's more to do with how did we contact them in the first place to say, how would you like to be contacted in the future, and can you provide your information for the future? And in many respects, it's kind of like if we think of the GDPR in the European Union, it's about how do we collect data about anyone who is from a certain age. It's about the right to be let alone, about the right to be forgotten about knowing where your data is held by and who is it held by and which registries are you on. So I imagine that we might end up in a sort of similar situation where, to some extent, people are responsible for maintaining their own registry of where did they sign up for things and what mailing list do they happen to be on. And of course, if they're sent a message, email or a text, they can always say no and not respond to it. So they can exercise their autonomy by simply not responding. And then the question is, if they don't respond after a certain period, do you exclude them from any further inclusion in the study, or do you apply for a waiver of the need for consent? So there are different processes that people would have to use for those kind of scenarios. But again, I think it's just thinking a bit more laterally about using the technology as possibly a more economic means to follow up people and a more practical means to follow up with people.
Thanks, Nik. I can see another question from Dr. Getty. Go ahead.
Nik, you've made the comment that we're making the information sheets and consent forms too complicated. and when you talk to people on ethics committees, we say they're too complicated, and then each time we put a study through, the ethics committee makes the pick more complicated. Why do we do that? What's going on there? Why are we continuing to make these information sheets that are 15 to 20 to 25 pages long?
It's very interesting. The short answer is that you can get into a bit of groupthink when you're on an ethics committee. And so what I noticed was that initially even the lay members would come on and they would have certain views, and then those would change over time. And there's a thinking of, oh, well, we better disclose this just in case, or, well, we need to put this information in there. And a lot of the information is also mandated by the companies themselves. So if it's a sponsored trial, for instance, they have paragraphs that they want to include. So, for instance, they have a whole page about confidentiality and privacy, when actually you can say it in 2 lines. So what I found, and I did this in 2001, was I just worked with the consumer groups and said, right, this is what we want to do. I presented to a variety of Health Consumers Council, Genetic Support Council in WA, and worked through these things and said, you write my information sheet and consent form. And so the consumer group came up with the text and built out the content, and it was a similar process that had been done in a couple of other places, including Peterborough in the UK, and Jane probably remembers what we were doing at that time. And so it was a very consumer-oriented information. And I think that that's one of the powerful things that we can do here, which I mentioned about the tiered consent, because we can have, and this is the work we're doing with ICGC on the participant engagement committee, is about whether or not we can have staged information. I've joked that if I ever go in a clinical trial, I don't want to read the patient information sheet and consent form. I want to read the protocol, because I want to know the lit review behind why they're even considering doing the trial and what's the statistical modeling. So, people should be allowed to do what they want to do with the information, or just say, yeah, it's a clinical trial. Yeah, okay, I want to be in that. So, it depends on what you need to disclose to a person legally to avoid court cases and Rogers and Whittaker, that kind of instance, versus giving people information that they can actually digest. And that's why I'm so fond at the moment of the electronic format, is because people can actually choose the information. We can capture metadata about that. We can even interact and ask questions through that and record their answers. Did you want to know more about this? No, I'm good here. I'm good with that, thanks. Are you sure? Because, we're a bit worried about the side effects on this. No, absolutely fine. I've understood that this could make my hair fall out. So I think that, this is why it's such an engaging potential for doing this. And I think that's why using these platforms, it won't really matter in terms of the length of a consent process or form, because it will be as long as it needs to be.
That's an excellent answer, and it does suggest that opportunity to keep tracking what people actually wanted and feeding that back to ethics committees, so that we get into that. It becomes a dynamic feedback to committee itself. I guess I'm just bitching at the moment because I got one of my trials down to 7 pages and year 11 language, and still got told to make it easier for people to read, and then watch the 40-page pharma study things go through and go, why am I being held to a different standard? But anyway.
Yeah. And it's been interesting, because when I was on ethics committee at St John's, and I was on the scientific advisory committee, but they would come to me and ask about the some of these information sheets. I'd rewrite them, and I'd rewrite the paragraph that we thought was acceptable, and the company would come back and say, well, we have our language, and we'd say, well, here's the thing, you can either fight us on it, in which case it will take a month to approve, or you can just agree, because the ethics committee agrees that this paragraph's fine, and we can approve it now. And it was funny how the lawyers then in the US suddenly went, okay then. So it was really, you just had to care to push back sometimes on them. But that involved, a midnight call to New Jersey. I don't know how many people are up to those kinds of things, because they just give up. They just go, yeah, whatever, 40 pages, all right. So I do think that, as I said, my emphasis has been really strong engagement with consumer groups about doing this work and really thinking about who we want to engage with and why we're, the whole thing about informed consent is about mutual understanding. It's about making sure that, we as researchers understand what the potential participants want and need and are going through, and they understand what we're trying to achieve and why we need them to participate and what the potential benefits to the community are. So it's that if we just turn it into a transaction of have you consented the patient, it's an incredibly disrespectful process. And really, we're talking about engagement and making sure of that mutual understanding. And that's why I think that the electronic format promises so much.
Thanks, Nik.
Thanks, Nik. I think that's just a fantastic place probably to end today. And thank you so much for a wonderful talk. And I think people have really enjoyed the Q&A as well. And I'd just like to thank everyone who's attended today, and particularly Toby Baldwin and Renee Mantle from the Biobank for their support of the seminar series, as always. Thanks so much, Nik. It was great.
Lovely to speak with you all.
And we look forward to continuing.